It's been a very exciting time in NMOSD because over the last 5 years, we've had multiple positive randomized clinical trials with evidence for new agents for treatment of NMOSD. And now in many countries, those drugs have been approved. So we have several monoclonal antibodies with 3 distinct mechanisms of action. We have C5 complement inhibitors, most recently Ravulizumab, but we've had Eculizumab for some time. We have Satralizumab, which is an IL-6 receptor inhibitor, and Inebilizumab, which is an anti-CD19 molecule. So I think, given the evidence for these agents, if the drugs are approved, in your patient's jurisdiction, they're very appropriate for clinical use. We know they're highly effective. And in patients who test positive for the aquaporin 4 antibody and have an appropriate clinical presentation, they should be instituted soon after diagnosis to prevent future attacks. We also have quite good evidence for the use of Rituximab. For some time, it's been used off-label. There was a smaller RCT showing evidence of efficacy in NMOSD as well. So I think that's also a very reasonable choice for a first-line drug. Of course, the drugs that are going to be used will depend on what's approved and also the funding structure in an individual's region. So in many countries, there still is limited access to these newer agents, and older drugs like Azathioprine and Mycophenolate, as well as corticosteroids, are commonly used for NMOSD. There may be some issues, though. Relatively speaking, our retrospective evidence suggests that their efficacy may be inferior to some of the newer agents. So I think in deciding on which drug to use for an individual patient, it's a complex decision. It has to be a conversation with the patient. I think most often we weigh, efficacy considerations and look at the severity of the disease of the patient in front of us. But other factors that are going to enter into the equation include the safety profile of that agent. If the individual has, specific comorbidities, they may have implications for what drug to use, or if they've had complications on other immunosuppressive drugs in the past. And then patients have their own preferences in terms of route of administration and the frequency of administration. So for example, Eculizumab is an IV drug, which is given every 2 weeks. And although it's very highly efficacious, some patients find that to be too onerous. So it depends what works for the patient in front of you.